evening, and we're excited to have Dr. Tae Hart with us again. Thank you so much for joining us. Dr. Hart has dedicated her career addressing the psychological challenges of chronic medical illnesses. This expertise is the foundation of the therapy she offers, ensuring that her approach is both informed and directly applicable to a patient's needs. Dr. Hart earned a BA in psychology from the University of Michigan and her PhD in clinical psychology from the University of Southern California, Los Angeles. That was a mouthful. Her training included an American Psychological Association approved clinical internship at the Palo Alto Veterans Affairs Medical Center and a research postdoctoral fellowship with the National Institute of Mental Health at Stanford University's Department of Psychiatry. Dr. Hart also has served as a faculty member at the University of California, San Francisco, and at Toronto Metropolitan University's Department of Psychology. Dr. Hart's research, primarily conducted at the Zane Cohen Center for Digestive Diseases at Mount Sinai, focuses on how chronic illnesses like cancer, Lynch syndrome, hereditary cancer conditions, and of course, gastrointestinal disorders, how it impacts the psychological well-being. Dr. Hart investigates quality of life, psychological distress, and symptom burden. And again, Dr. Hart, thank you so much for joining us.
You're welcome.
We'll
Thanks.
leave it to you.
All right. Well, I've got some slides prepared. And then, of course, we'll have time for questions and answers afterwards. Let me just go ahead and try and find my presentation. Here we go. All right. So today I'm going to be talking about psychological and social aspects of living with IBD, but I'm going to have a big emphasis on therapy. Um, so, as was already stated, thanks, Kevin, for reading out my bio, very lengthy. I'm a clinical health psychologist. What does that mean? That means that I have a PhD in clinical psychology, but my primary focus is on health conditions. I'm not a physician, but I work with an awful lot of physicians, and I've been in medical centers throughout my entire career for the last 30 plus years. And I moved here from the University of California, San Francisco. I worked at the Center for Colorectal Surgery, where I spent a lot of time with colorectal surgeons, which is how I learned so much about IBD for many, many, many years. And then I decided that I wanted to be in a more tenure track and more stable situation. So I ended up applying to all these jobs. I have a brother that lives here in Toronto, and I ended up at Toronto Metropolitan University, otherwise known as Ryerson. And then 15 years ago, I was approached to join the Zane Cohen Center for Digestive Diseases and I for the familial GI cancers unit. And my work is primarily on Lynch syndrome, but I also study non-hereditary colorectal cancer, familial gastric cancer, um, some on IBD as well in terms of my research. My clinical expertise is focused on assessment and psychotherapy for people who are living with chronic medical conditions. I would say half of my practice tends to be people who have cancer and specifically dealing with colorectal cancers, but also many other kinds of cancers, and lots of people who have Crohn's colitis, as well as multiple sclerosis and Lynch syndrome. And if you want to know more about my clinical practice, you can find me at www.drtahart.com. Pretty easy to find on the internet. Not everybody is muted and it's creating noise. So if somebody could handle that, I would appreciate it. So let me tell you a little bit about anxiety and depression and IBD in terms of what the research shows us. It's really common. About 1 in 3 have experienced anxiety. 1 in 4 people experience depression. Anxiety and depression and IBD is higher than people that have no health conditions, but it's quite similar for people that are living with other chronic illnesses like rheumatoid arthritis or diabetes. As many of you have the lived experience, those symptoms of anxiety and depression, of course, are going to be higher when disease is active versus in remission. And actually, you're at highest risk of depression and anxiety in that first year post-diagnosis. And I think a lot of that is informed by living, like having to live with the uncertainty. You don't know what's going to happen. Of course, none of us ever know what's going to happen at any moment, but that is particularly true in IBD. That's also true in cancer. And while probably most of you don't care about where these citations are coming from, if you want, you can take a picture of the slide. If you're interested in reading more, these are the articles that the data are coming from. So, what are some of the common psychological reactions to IBD? They're all over the place. When people first get diagnosed, it's shock, denial, disbelief. Later, people experience some anger, irritability. As I mentioned, anxiety and depression are incredibly common. But people can also experience a lot of hopelessness, especially if treatments aren't working. Um, Many people report panic. IBD is unfortunately a condition that leads people to feeling socially isolated or lonely, especially if it hits you at young ages. I've had people in my practice who have gotten IBD as young as 8 years old. It's hard to relate to other people if they're not going through these things. And then, of course, hopefully, people get to a place where there's some acceptance or resignation of having to live in a body that is not doing what it is supposed to do. Those symptoms, the psychological symptoms, are they're often tied to important kind of medical, what I call medical management timelines. So um, it takes people often a very long time to get diagnosed, especially if they're young. They get blown off and been told that they have hemorrhoids or some other kind of very benign condition. So waiting for appointments, waiting for screenings, diagnostic results is a time of high anxiety. The time of diagnosis, having to make treatment decisions, the treatment itself, depending on what it is, can bring about depression and anxiety, especially if you're awaiting surgery and having kind of doing that countdown. Follow-up screenings, scanxiety is what it's called. So just like waiting to be scanned and then finding out the results can be a time of high anxiety. And of course, if the disease relapses and continues to advance. And again, I don't think that there's any, I think there are some specificities about IBD that lead to these issues, but this is exactly what you see in people who are living with cancer or multiple sclerosis or rheumatoid arthritis or any other kinds of autoimmune conditions. IBD data also show that it affects quality of life. So the psychological stuff we've talked about, one thing I haven't talked about so far is the incredible commonness of having post-traumatic stress types of reactions to near-death experiences or badly performed procedures and impacts on body image. Not everybody has the same kind of experience through IBD. So if you haven't had these things, great. But if you have, please know that you are not alone. Obviously, there's a bunch of physical symptoms that impact quality of life, not just the bowel stuff, but pain, fatigue, and sexual dysfunction. Those psychological and physical symptoms can impact people's ability to work or engage in their activities of daily living. A huge part, I think, of IBD to manage that nobody really has like a kind of a skill set that's ever given to them is how do you manage your relationships? And in prior talks, that I've given, we've spent a lot of time talking about what is it like to be in a couple, where your partner is either a caregiver for you, or you are the caregiver of somebody with IBD, or if you're a single person with IBD, how are you supposed to date? When do you disclose? So, I've talked about that in the past for this group. That's not the focus of today's talk, but I think it's important to note that IBD has those impacts. And then professionally, um, I would say I'm talking more and more in my own practice with people about ableism and kind of uh, how their coworkers react to IBD, which is often an invisible illness, as well as bosses and the issue around workplace accommodations. Sexuality is something that comes up for many people, like the ability to have sex, especially if people are dealing with incontinence or dealing with an ostomy. People worry about becoming dependent on their caregivers. Um, we talked a little bit about IBD related stigma that comes up both socially and in workplaces and isolation. And then I think it's also important to mention the spiritual and existential impacts of living with a chronic condition. Um, and it does come up for a lot of people, the kind of the why me question. Um, Many people have a why not me as an attitude, but a lot of people do feel that this is a punishing illness. And what does it mean? They feel a bit abandoned by if they have spiritual beliefs that can either kind of protect them or also lead them to feel abandoned. I think another kind of really big piece is like, what does it mean? What does it mean to have an illness that may thwart you from reaching your full potential, or at least the idea that the life you imagined for yourself is not the life that you're living in this current time, or that you're going to live, or going to be able to live. And so I think those existential concerns are really, really important to think about and to find meaning in one's life in the face of IBD, I think is a major goal for all people, whether or not they end up deciding to talk to a therapist or not. I think these are all I think these are questions that all of us have to face. And as people age, 90% of people over the age of 65 have at least one disabling condition. So um, if you're not at that age, you will be joined by the ranks of people that are dealing with this. So I think that these are normal questions of aging as well, but there are things that have to be addressed by people much younger than they quote ought to, if not for IBD. Um, there are some data that I wanted to talk about just in terms of disease severity or activity being associated with more psychological symptoms. So corticosteroids themselves can cause psychological symptoms, and we see that in more than half of people. Um, IBD itself creates pain, fatigue, and life disruption. And there are some studies that show a relationship between increased stress and worse psychological symptoms and disease activity. And I think one thing that people have to face, probably from more of their family members or their friends more than maybe physicians, although I'm sure people will say what their experience is later, is the idea that, well, you stop stressing out because you're going to make your disease worse. And it's like, we all are facing stress. We are all living in a world that is literally burning down. And the idea that you're to blame for your IBD is really deeply problematic. But it is important to know that stress and IBD do have a relationship. And that doesn't mean that it's your fault, but it does mean that it's important to kind of figure out ways to manage the stress the best that you can to your ability, knowing that there is no such thing as a stress-free life, especially right now in these days. So, what's disease-related stress and IBD look like? I mean, these are just some of the things that research shows, but your mileage may vary on this. So, um, disease-related stress might be anywhere from toileting concerns, bowel control, various symptoms, worry about the unpredictability of IBD, medications and treatments. Um, Parents often report the worry about passing IBD down onto their kids, having a lack of information, like just not knowing how this is supposed to go, needing to keep close contact with healthcare providers, and I will, while this wasn't part of this particular study, people not feeling like their healthcare providers are giving them quality care. And then finally, the sense of always having to focus on IBD. Now, there are data that link the brain and the gut. This is not a made up thing. There's like whole lines of research on this. The data tend to come from what we call observational studies. So these are large studies of large groups of patients. And what they show is a bidirectional link between IBD and mental health issues. So IBD symptoms and relapses cause anxiety and depression. But in return, stress and anxiety and depression activate a part of the autonomic nervous system called the sympathetic nervous system. So there are two parts to the nervous system, to the autonomic nervous system. There's the sympathetic, that's called fight or flight, and there's the parasympathetic, and that's rest and digest. That's the kind of thing that helps people. Parasympathetic is the kind of um, when you meditate, you activate the parasympathetic nervous system. When you're stressing out, that's when the sympathetic nervous system is activated. And many people who are living with chronic illnesses are kind of in this chronic state of sympathetic responding because there's so much stress. That stress does have pro-inflammatory effects on the GI tract. That doesn't mean you caused it and that you're to blame for it, but it does mean that there is a link between these things. There are some studies, a few cohort studies out of the UK and Switzerland, that show that elevated depression and anxiety are indeed risk factors for disease recurrence and flare up, but we don't know too much about the specific markers of inflammation. We also see that depression and anxiety for people with IBD are associated with greater healthcare utilization that go above and beyond disease severity. So people are really trying to find answers to their questions and trying to find support. So that leads me to wanting to tell you a little bit about something called gut-directed or gut-related hypnotherapy. So what is that? This is addressing that there's a connection between the brain and the gut. So it's a therapeutic technique that includes a lot of imagery and relaxation techniques. Hypnotherapy makes it sound like somebody's waving like I don't know, kind of a stone in front of you and you watch it go back and forth. That's not what modern hypnotherapy, I mean, I guess it could look like that, but that's not what modern hypnotherapy is. It's basically this deep guided relaxation. And once the person's relaxed, the hypnotherapist suggests changes to one's thinking, behavior, perception, sensations, and feelings. And so it's quite different than a guided meditation. So if you've ever used Headspace app or Insight Timer or just meditated on your own, there's not necessarily guided recommendations. With gut-related hypnotherapy, these are specific suggestions that are helping you to manage symptoms of IBD like pain. So imagining your pain going down, imagining the GI tract healing. Like there's a bunch of these suggestions that are done. There's there's hypnotherapy for almost every problem in the book. I mean, you can find tons and tons of hypnotherapy on YouTube, for example. So I'm sure if you kind of wanted to check it out, you could. What are the data, though? What's the evidence base on this? Gut-related hypnotherapy actually, believe it or not, has a solid evidence base in irritable bowel syndrome and is associated with symptom relief. Irritable bowel syndrome is not IBD. IBD is a disease process. So when we look at the IBD literature specifically, and I've got the citation right down there, so it's a review that's just been completed in the last year, there's just been 5 randomized clinical trials. And what can I tell you? The results are mixed. Some trials show improvements in remission from IBD, others don't. One study showed an improvement in the specific inflammatory marker IL-13, and another study showed that people reported fewer liquid stools and improved abdominal pain. In terms of psychic outcomes like quality of life, anxiety, depression, the hypnotherapy groups were similar to the control groups. But when you look at smaller groups of people, like a case series of like maybe 10 or 13 people, and they actually can sit down with them and ask them, well, how did you find this? And really kind of get into their experience. People say they do experience improved IBD quality of life after the hypnotherapy. Now, hypnotherapy is not psychotherapy. Remember, I described it to you. It's basically a relaxation technique with suggestions. Psychotherapy, or I should say, the psychotherapy that has the best evidence for people with IBD is cognitive behavioral therapy. I'm going to explain to you what CBT is. And in the general population, just with people, all comers, all kinds of people, data show that CBT has a strong positive impact on depression. And it's been shown in probably thousands of studies at this point. What about specifically for IBD? A meta-analysis, which is basically like when they put a bunch of studies together and they take the raw data and they kind of do these various techniques to see what is the effect if we combine all of these studies. So in this study, they looked at 25 randomized controlled trials of psychotherapy with people with IBD, and it shows small but significant effects. So improvements in depression, anxiety, perceived stress, and quality of life. The data look even better when you select people out who aren't doing well, right? So in a randomized controlled trial of people who have very low quality of life scores, they were randomized to CBT versus a waitlist control. Waitlist control just basically means for the next 12 to 16 weeks, you're not doing anything except waiting to get your number come up, and then you'll start getting the psychotherapy. So when they look at people who are waiting for the therapy versus people who are actively have done the therapy, there are much larger size effects. So that means that CBT has greater efficacy for people who have more to gain from psychotherapy. Like they start off not doing great. When I say not doing great, I don't mean from an IBD perspective. I mean from a quality of life perspective. So the outcomes included better anxiety, better depression, and improvements in IBD specific quality of life and just general mental health quality of life. So what is CBT for IBD? Basically, the problems that could be addressed in CBT for people with IBD are pretty broad. Could be dealing with health anxiety, catastrophic thoughts about the present and the future, depression, health, social isolation, in particular relationships with other people. Stress responses, so like the anxiety around scans or anxiety around going to see one's doctor, having problems with healthcare providers. So there's a big problem-solving component that's part of CBT. And then I mentioned this anxiety related to procedures. So how are the problems addressed? Like how does CBT actually work? And it's I would say it's multi-dimensional. It depends on what the person needs. But there's anything from teaching people how to relax, breathing techniques to bring people into more parasympathetic responding versus sympathetic responding. So bringing them into a state of so that they're not so activated. Um, some CBT people will teach you how to meditate, um, decreasing avoidance through things called behavioral experiments. So that's not an actual experiment with test tubes, but if people are feeling really anxious about specific things, we might design a way for them to approach the anxiety in a very safe way and kind of look at how they're feeling before and after and building in coping responses to the thing that they're feeling anxious about. We also teach people how to restructure their catastrophic thinking and negative thoughts. And sometimes our thoughts are just correct. Sometimes there really is something very catastrophic going on. And so, what do we do? We're not going to try and change thoughts that are accurate, but we're going to move into problem solving. We're going to actually figure out a way to solve problems together. And the thing that I think all people have trouble with is acceptance. I think we live in a society that does not prioritize accepting things that are difficult to accept. And I think that acceptance is like kind of one of the pillars of CBT. If you're working with a therapist that actually understands something about chronic illness. So we talked about the fact that there's this gut-brain connection. So does psychotherapy actually help improve disease status? The answer is we're not sure. It doesn't look it doesn't look overwhelmingly like it's actually changing the course of illness. One study that I found showed that CBT did not positively impact disease activity indices, C-reactive protein, which is an inflammatory marker, hemoglobin, platelets, or white cell count. And they looked at people over the course of 24 months post completing the therapy. You also see a similar lack of findings, not just for CBT, but therapies that like are focused on stress management or mindfulness-based therapies on IBD activity. And meta-analyses, those are like those studies that combine many, many different studies. They don't show any significant effect of any kind of psychotherapy on the risk of relapse or on clinical disease activity indices for ulcerative colitis or Crohn's. But research is ongoing in this area. And, it may take us another 10 years to kind of know if there are any positive effects of psychotherapy on disease activity. I guess the takeaway message is, mm, if you're thinking about getting extra help, don't necessarily expect it to improve your IBD, but do expect that it's going to impact more of your quality of life and how you're coping. So I wanted to talk a little bit about how much do people even want to get help through treatment? And this is a large study of a German cohort of IBD patients, over 600 people that were recruited through a chapter of the European Federation of Crohn's and UC associations. And they asked people a lot of different questions, and the ones that I'll show you the results for, they asked them about, do they want additional psychological treatment, and how much are they worried about progression of their illness? And in this sample, around 50% wanted psychological treatment, additional psychological treatment. And I'll just summarize the findings here for you. So in the blue are people with ulcerative colitis, and in the orange are people with Crohn's. So people who had more fear of disease progression, had prior treatment, like a psychological treatment in the past, and were non-smokers, had a higher demand for psychotherapy. For people with Crohn's, when their quality of life was worse, and people who had not yet had IBD surgery wanted more psychotherapy, meaning not more psychotherapy, but they wanted psychotherapy as an adjunct to their treatment. So the takeaway here is that most people, at least in this cohort, wanted additional treatment. But what happens between the provider and the patient? And so this is a study looking at what people wanted versus um, what their IBD provider discussed with them. And what you can see here is that about half of people wanted referrals for mental health treatments. They wanted to talk about the impact of IBD on their emotions, mental health, the impact of stress on the IBD symptoms, and the IBD impact on their quality of life. And while around 50% of providers were willing to talk about stress of IBD and IBD impact on quality of life, many fewer were willing to talk about specifically mental health, and only 17% were reported to give a referral for mental health treatment. Now, this is again done not in Canada, where we don't really have much publicly funded mental health treatment. But all to say is that this is not always kind of first and foremost on the minds of providers. So what I'll move on to next is talking about how can we find ways to support psychological health, knowing that you're going to be the one kind of driving the car on this one. And there are three areas that we'll talk about: psychiatric medication, psychotherapy, and self-management. So in terms of psychiatric medications, and you can take a picture of this, and if you're thinking about starting one, this is a good slide to show your provider. Um, the four that are kind of first line antidepressants in terms of IBD are fluoxetine, sertraline, citalopram, and mirtazapine. I like this slide because it talks to you about what the start doses are. I'm not promoting this. Like if people are thinking about going on an antidepressant, I want you to have the information. You don't have to. You never have to. I'm not saying you have to, okay? Just I want you to have the information to take to your doctor if this is something that you're thinking about or you have been thinking about. I like that they talk about the positives and the negatives here. So I like that for the SSRIs that are on this list, fluoxetine, sertraline, citalopram, they're saying that 20% of people do experience GI symptoms in the first few days. They always recommend taking it with food, specifically breakfast, and start on half of the dose of the start dose to minimize the effects. Um, the fourth one, mirtazapine, is different in that it does cause weight gain, which is desirable for people who have lost a ton of weight because they've been too sick to eat. But about 20% of people just have too much daytime sedation to tolerate it. But it does have good effects on sleep, and it also has an anti-nausea action, and is good for anti-anxiety. So that's all I'll say about that. I want to talk about specifically how do you get psychotherapy in Ontario, especially if you're not working, you don't have additional psychotherapy benefits through a secondary health insurance. There's something called the Ontario Structured Psychotherapy Program. Usually I don't put like the whole URL into a slide, but because you guys don't have access to these slides, I thought, let me give you the links so you can take a picture of the slide. You can have your doctor refer you to this program. You have to make sure that they specify the Ontario Structured Psychotherapy as the reason for referral, but you yourself can also self-refer to the program. There is a wait list. There is a wait list for everything in Ontario, including not mental health care. I also wanted to talk a little bit about other kinds of therapies. The OS Ontario Structured Psychotherapy Program is CBT. You don't want CBT, there are mindfulness-based programs. There are many, many groups in the GTA and beyond. Many of them are held virtually. Some are held during the day. Some are held at night. There's if you want to, you can find this. The fees are often much, much less than one-on-one psychotherapy, but you are in a group. Mindfulness is actually really important because it can have an anti-inflammatory effect because it's activating the parasympathetic nervous system. So it can be incredibly, incredibly useful. Um, I also wanted to tell you about how you can get access to uh, kind of the more psychological pain treatment. So Toronto Academic Pain Medicine Institute has offered in the past OHIP funded mindfulness-based stress reduction and mindfulness-based cognitive behavioral therapy groups. And again, you would need a referral for these things, and this is the link to that, to pain treatment programs. Also, part of the Ontario Structured Psychotherapy Program is something called Bounce Back. It's delivered over the phone. It includes workbooks and bi-weekly personalized mental health coaching. I provided the link there for you. You can either self-refer or get referred to the program. They also have something called clinician-assisted bibliotherapy. So you get kind of a free CBT self-help guide and a plan for readings and exercises and weekly 30-minute sessions with a therapist. It's a little different than regular psychotherapy. It's kind of much more structured and is focused on doing your own work and your own readings. There can be internet-based CBT delivered online and guided by a therapist to work through the modules. These are all, again, OHIP funded programs. There's a number of apps and self-guided programs that I sourced for you. I spent many, many, many hours on the internet trying to figure out what is out there if you're not able to access psychological help because it's just simply out of reach financially. So there's two IBD specific programs. There's something called Mind Over Gut and Tame Your Gut Online. And both of those have been part of research projects. I think the Tame Your Gut is out of Australia. I've looked into all of these and they look very interesting and very reasonable. There's also a few self-guided programs that are not IBD specific, but will help with depression and anxiety. So one is Mindshift app, and that's developed by Anxiety Canada. And there's two pain specific programs that I located. One is called the Power Over Pain Portal, and one is Pain You Online, and that's part of the Toronto Academic Pain Medicine Institute. And these are excellent, excellent resources that have been, I think, are very well developed and worth taking a look at. And then in terms of other self-management, there are some IBD specific apps. You may have looked through these. If you don't know about them, they're useful. You can Google them. One is called My Gut. It's from the Crohn's and Colitis Canada organization. There's also My IBD Care and Life MD, which is developed for IBD. And I think there is a small fee to use that specific app. These are not necessarily focused on depression and anxiety, but more on just sort of managing IBD. And as part of managing IBD, they do talk about some psychological issues and how to deal with those. And that takes us to the end of what I had to present to you today. I'm very happy to answer questions or give you any other information that I can give you that maybe isn't related to what I presented. Just go ahead.
Hi, thanks for your presentation. I do have a question that's semi-unrelated to what you presented, but related. Um, Without going into my whole medical history. Over the past little bit, I've been struggling with focus related to what I think there's a pain component unrelated to my IBD, but I now have endo, so it's kind of like all inflammation. I tried to get an ADHD diagnosis to see if that was it or if it was pain, and I ended up getting you have too many problems to actually diagnose.